Okay, let's talk about psychotic disorders. For today, I want you guys to understand the neurotransmitter theories behind the psychotic disorders, mood, and anxiety disorders. We've talked about them before, but I just kind of want to summarize all these things together now. Know the characteristic of the specific psychoses. And so when I say psychoses, I just mean the symptoms of psychotic disorders. Understand the etiology of audio versus visual hallucinations. We talked a little bit about that already with the substance abuse disorders. Know the risk factors for the psychotic disorders, understand the pathology of the psychotic disorders, and understand how to diagnose the different ones. We'll go into the basics of management, and I have a little section on the actual antipsychotics, but again, I don't want you to memorize specifics about each antipsychotic for this lecture. It's just for your information, just passed on some tips. And then we'll talk about the basics of detentions and commitments for anything really that's where patients are harm to themselves or other people, but you see it a lot in psychosis, obviously. Now that we're finally getting into psychotic disorders, we really are covering all three of the basic, things that we see in psychiatry. That's I guess, our bread and butter, and butter. So more butter. So mood disorders, anxiety disorders, and then the psychotic disorders. So for the mood disorders, remember, it's a serotonin deficiency. We treat them with SSRIs. Sometimes we use mood stabilizers for bipolar disorder. And those are our things like Prozac and Zoloft. Again, remember when I use the term SSRIs, it could be SNRIs or even the novel antidepressants too. For anxiety disorders, now more serotonin deficiency is our main theory behind why that happens. And so we also use SSRIs and mood stabilizers. You see a little bit more use for benzodiazepines here, but again, not too much. So again, Prozac and Zoloft. With psychotic disorders, the main mechanism of the disorder is a dopamine excess. Okay, so antipsychotics that we use are actually going to be dopamine antagonists to try and reduce the effective amounts of dopamine. And remember from our substance abuse lectures, when we talk about stimulants, most of those things are dopaminergic. So you can kind of see how you can get psychosis induced, meth use and from stimulant use. So here we're trying to reduce that psychosis by using antipsychotics, by reducing that dopamine. And the medications, a really old standby is something like haloperidol there, and then some of the newer medications, things like Abilify. So for specifically schizophrenia, it is one of the psychotic disorders. It's the main psychotic disorder, but it's just one of them. And we'll talk about the other psychotic disorders later on. But the World Health Organization definition of it is a severe mental disorder that is characterized by profound disruptions in thinking affecting a person's language, their perception of the world, and the sense of self. And of course, there has to be an impairment of function, work, social, basic life skills. And this picture here, this is, it's one of those internet things where, oh gosh, see how the self-portraits of Pablo Picasso progressed? Didn't that show that he had schizophrenia? I mean, I don't know if he really had schizophrenia or not. I doubt it, because, it's an interesting thing to look at this and say, oh my gosh, look how more chaotic his thinking becomes and his visual perception. And that's true. It's interesting to look at these things and think that. But, Picasso's paintings are incredibly ornate and intricate. They're done by a person who has an immense control over their artistic abilities and their sense of what they want to portray. And that's not what you see in schizophrenia. The disordered thinking that you see with schizophrenia, that's that's a disabling thing. You know, you look at these pictures on the bottom row, again, there's a lot of insight and thought that goes into those and a lot of control. A person with, you know, with full-blown schizophrenia wouldn't be able to put those things together. So, but it is an interesting thing to at least look at. So when we talk about the symptoms, what's the clinical presentation of schizophrenia or any psychotic disorder? It's these three categories of symptoms, or say, okay, so positive symptoms, negative symptoms, and the cognitive symptoms, okay? And so the positive symptoms, these are delusions, hallucinations, disordered speech and thinking, and then abnormal behaviors, which we'll talk about, okay? Then we have negative symptoms, and these are going to be the lack of things that we would expect from a normal affect in a human being. So avolition, not having any motivation to do things. Flat affect, which is, again, our nonverbal communication with people. So when patients don't have that at all. Anhedonia, not enjoying things that they actually do. And this one here is more the pure definition of anhedonia. For depression, we talked about anhedonia as patients avoiding things they didn't like to, avoiding things that they like to do as a sign of it. But here, these patients that have real, true schizophrenia, they just don't have any pleasure from anything really. Apathy, alogia, not speaking really, and then asociality, just like not having to, not being shy or not wanting to be with people, just not having any sense of being in a community. And then we have our general cognitive symptoms too. So things that just go along with the fact that patients with schizophrenia really suffer from disordered thinking, memory loss, problems with executive functioning, short attention span, and slow processing speed. So when I talk about psychoses, they generally refer to positive and negative symptoms, whereas the cognitive symptoms, again, just kind of go along with the fact that this is an unhealthy brain. So US estimates from the National Institute on Mental Health estimate between 800,000 and 2.1 million people in the United States that have some form of schizophrenia. Now, the range is, it's a pretty big range. It's a threefold range almost. And so, that has to do with what they define as psychotic disorders. My guess is that lower number is more for pure schizophrenia versus the 2.1 million is more based on things like brief psychotic disorder, which could occur, with when you have a working diagnosis of a patient and you're not sure if it's a substance abuse or organic medical issue. But we'll go through some of these psychotic disorders later on. Like I said, brief psychotic disorder, schizophreniform, delusional disorder, schizoaffective. Those are the whole range of psychotic disorders. The worldwide estimate from the World Health Organization is about 21 million, so 0.3%. And so that seems more in line of true, schizophrenia. It's a pretty rare disorder. It tends to begin late adolescence or early adulthood. I think we've all heard of, when the story of a patient who was doing well up until a certain point and then just cracks, around the time when, a long time ago when I was in school, there was a story of a medical student who, obviously he'd been doing well for himself, and then once he was in medical school, just had a psychotic break. And I never followed up if it was actually he continued on and progressed into schizophrenia, but he definitely had at least a brief psychotic disorder. Males tend to their peak tends to be a little bit earlier, and you can have mild or isolated symptoms in childhood. Now, those tend to not progress into schizophrenia, and they're extremely, extremely rare. Suicide rate is about 4.9%, which is about 0.02% in the general population. So 4.9%, it's a lot. That mimics the depression rate of suicide. One interesting thing that we'll talk about, is that borderline personality disorder. We'll talk about that later. The suicide rates there are actually much higher than in depression and in schizophrenia. The reason I bring it up is, here the picture on the right, we've got, our new hospitals, but the one on the bottom right is the LaRue Mental Health Institute. It's the older building. And when you go into like a state mental institute like that, what you'll see is, of course, a lot of schizophrenic patients. And then what you may not realize is that you actually, the other, a third of the patients there are borderline personality disorder. So you've got 2/3 of patients that are schizophrenia to the point where they can't be controlled medically. They're constant harm to themselves or others. And then you've got borderline personality disorder, which, again, unless you're familiar with it, it may be an interesting thing to think that just a simple personality disorder could end up in the State Mental Institute, but it's because of that suicide rate and extremely impulsive patients, but we'll get to that later. So some other stats, concerning stats to look at, the loss of life is estimated to be about 28.5 years. And there's a lot of different reasons for it. It's not just the obvious one of, the increased suicide rate, but, patients are not healthy. They're physiologically not healthy because of the things that are going on in their brain, but also they can't take care of themselves. So the difficulty here is just, they're deteriorating, but they don't have the skills to really take care of themselves on top of that. The financial burden is much higher than in other mental illnesses because patients that tend to have schizophrenia, not only can they not take care of themselves, but they generally, not generally, but a lot of them cannot be taken care of from traditional family perspective either. Okay, so that's why we have to have large institutes. Again, 2/3 of the patients are probably going to be patients with schizophrenia. And when you meet patients, like I said, when you go to LaRue or any state mental institute, those patients have been there for years and years and years, if not, basically their entire adult life. So it's like I said, yeah, it's a huge financial burden in addition to the psychological one. So let's talk a little bit about the traditional mechanism here of schizophrenia and how, how we use our medications to help things out. So the original theory was by Arvid Carlsson, where again, it's a dopamine excess. And, that led to the functional understanding and development of antipsychotics, of course, as a treatment, since antipsychotics are dopamine antagonists. So more specifically, excessive dopamine activity on the D2 receptors in the mesolimbic pathway. That's what's responsible for positive symptoms. Okay, so excess D2 activity leads to positive symptoms. Now, we've all, taken, neurology courses, and so that the brain is not just a simple on-off switch, and increased dopamine here means that increased dopamine across the body, right? You can increase dopamine in one place, and it can have further effects down the line on GABA or glutamate neurotransmitters, right? Which will causing different effects, or dopamine effects here causing inhibition there. So it's not just that sort of situation. It's easy enough to understand the positive symptoms, but the negative symptoms are a little bit different. It's the lack of D1 receptor activity in the prefrontal cortex and the mesocortical area that causes the negative symptoms. Okay, so you can see there's a difficulty here with, with how do we treat this if we're using traditional antipsychotics that tend to just call dopamine antagonism. You can see how they would definitely affect the positive symptoms, but may not have that much effect on the negative symptoms. And that's what we saw with our traditional first generation antipsychotics. You didn't see much negative symptom improvement, but as the pharmacology has improved these days, we're getting a little bit better. It's still difficult to treat the negative symptoms of true schizophrenia, but we are having, our tools are better now to kind of affect that change. And then, of course, there's also the D3 receptor issue too, and you'll see that going on where it's not, there's just an added twist when we talk about D3 receptors. Now, what about the side effects of these medications? So, antipsychotics traditionally are they're not medications that you know, everyone feels comfortable starting because they have some pretty debilitating side effects, and one of them is through the nigrostriatal pathway. Okay, so we'll talk about extrapyramidal syndrome and tardive dyskinesia later on, but it's this pathway that's kind of responsible for these EPS and tardive dyskinesia symptoms. We'll get to that later on. And then, you know, again, the effect of these antipsychotics on the tuberoinfundibular pathway increases causes hyperprolactinemia, which causes gynecomastia and galactorrhea. So that definitely happens too. And so, you know, it was pretty common in the past 10 years to use risperidone and risperdal in children, especially in male children, and you would see gynecomastia in them too. So these are two side effect pathways: the nigrostriatal pathway and the tuberoinfundibular pathway. Cognitive deficit. Remember, this is apart from the traditional psychoses of the positive and negative symptoms. So the cognitive deficit in schizophrenia tends to be part of this D3 activity. And so things like memory loss, language, executive functioning, processing speed, attention inhibition, sensory processing, these things have been more difficult to address too because of that D3 receptor. But again, some of the newer antipsychotics we use tend to have better effects now. So let's start off with the positive symptoms.
Do you ever drink to escape from reality?
The first symptom that we're going to talk about are delusions, and this is, you know, you see this a lot outside of psychotic disorders too. But, you know, it's a false belief that cannot be explained by culture or education. And the patient cannot be persuaded that the belief is incorrect. So this is not the same as an overvalued idea, though. Something like religious beliefs or political beliefs, things like that. Those are just overvalued ideas. Kind of the example I give for this is my first day when I was at LaRue. And this is just as a student, I interviewed a patient, and he was just kind of, you know, laying in his room, and I asked him, so, hey, how you doing today? He's like, other than, you know, the axe attack last night, I'm okay. And, you know, he totally deadpanned it to me, and I thought he was just, you know, I just thought he was joking. It's one of those things when you talk to someone and they say something like that, you know, you assume everyone, not that everyone's okay in a mental institute, but still, he didn't lead on that anything was a problem with that. And, you know, so I kind of joked back with him that, oh yeah, gosh, it must really hurt to do that. And he gave me this look like I was crazy, just get out of here, you know. So for him, it was common that you know, from previous kind of experiences, he'd always had this feeling that he'd been attacked from the night before, and in pretty gruesome ways, and so that was kind of his level of delusions. So here are some of the common types of delusions that you see. Erotomanic, meaning that someone is in love with the patient, or they think they are. And honestly, I've seen this manifest as a patient that breaks into their neighbor's house because they think that that neighbor is their wife or husband. In this case, it was a young patient who thought that this man's wife was his wife. And so, you know, obviously the way that comes into legal issues. Delusions of grandeur. I think we all pretty much know this one, that a patient may believe they are president, and it's actually believing they are the president is a pretty common one. And it has to do with the delusions of ideas of reference, where patients believe that the TVs are talking to them, and so they kind of confuse that with being the president of the United States. And we'll get to ideas of reference. Guilt, that they've committed something, a grave sin or error. There's a lot of self-persecution that goes on with that one. Delusions of jealousy, that a spouse is unfaithful. I have a patient who, because of, again, the disordered thinking and perceptions that are going on in the world, he thought that his wife was in a bunch of pornography, and had obviously that's problematic. Passivity, that you're controlled by outside influences, and one of my rotations was at LaRue, and so I got to see a lot of these very destructive or very severe delusions. So this woman who'd been there for, I think she was there when I met her, about 18 years at that point, but the current delusion that she was in was that she constantly thought that NASA was slowly turning her into a robot. You can see where the part of the disordered thinking and paranoia and not feeling like you're not really in control of yourself can cause some of these things in a, like I said, in a disordered way. Delusions of persecution, that there's other people outside trying to interfere with you, or that they're the ones that are stopping everything that goes wrong in your life. Delusions of poverty, that they think they're poor when they are not. Again, you can see this with homeless people that have mental illness, and this is I'm not saying that all homeless people have this one, but this is a very specific one where there are people that have support systems, but because of what's going on, or the ideas of what's going on in their life, they choose to be homeless. And then this is the ideas of reference, belief that external events refer directly about them. Again, you hear a radio or you see a TV on, and if your perception's off, you may think that that's a discussion with you. Somatic delusions, that body functions have been altered or smell bad. And then thought control, that someone else is putting ideas into their head. Again, kind of related to auditory hallucinations, or again, just the fact that you don't really know what's real and what's not real. So a little aside here on delusions, when you hear the phrase paranoid delusions, it's a reference to, or it really describes all these things that we just talked about. Because if you think about schizophrenia, again, having this disordered brain, patients really have a difficult time telling what's real and what's not real because of the way they're perceiving things. And so they build a really big distrust of what's going on. So they just don't trust things. It's the basis for a lot of these behaviors. They can only really believe what they think is true, which again, when you're having problems, it's difficult to know what those actually are. And so patients can be very agitated and violent because of this. Again, it's the paranoia, it's just a big driver for a lot of schizophrenic patients. The next psychosis we're going to talk about are hallucinations. So these are the false sensory perception in the absence of a stimulus. We've already talked about this, but auditory are more related to psychosis, where the visual types of hallucinations are more related to substance abuse and medicine side effects. So how do you know if someone is having hallucinations, right? The only way you can tell is you ask, okay? But that makes things difficult because obviously, it's not a very objective way to get to that, and there is none. It's an interesting thing to think about. The SIWA that we talked about last time, there's not a lot of objective things on that exam or on that scale, too. So, yeah, I've always talked about these issues with objectivity in psychiatry. This is definitely one of those areas. So, what you can do is if patients say that they're having hallucinations, you really try and get at, is it really something else first? Tell them about. We tend to there are times where it's more normal to have hallucinations or at least see things that aren't really there. We have hypnagogic uh, or falling asleep things. So like when our brain is kind of lulling to sleep, we can see things. You kind of think of with kids, seeing like the boogeyman and stuff like that. And then also hypnopopnic, awakening hallucinations. So anytime the brain is kind of coming in and out of those deep stages of sleep, it definitely can play tricks on us. The other thing you want to differentiate from is illusion. So seeing something, but it's actually, there is something there. So, right, it's just a misinterpretation of stimuli. And so, really common one here is from SSRIs. The visual type of hallucination that serotonin causes, or at least low levels of it causes, are like shadows, or in the periphery, kind of like a flickering of light and things like that. So, sometimes people misunderstand that as, oh gosh, I think there's I swear I know there's not a mouse in the room, but I keep seeing something move around in the corner of my vision, and I look over and there's nothing there, right? Or they're like sitting in a room and like, imagine you're sitting in a room and a window is behind you. If someone were to walk in between you and the window, well, then you would notice the shadow in front of you, right? You'd notice like a change of light in the room. That tends to freak people out too, because then they think, oh, there's someone's in here walking around me, right? Or something's going on with the lights. So yeah, you want to differentiate from illusions and like those normal hypnagogic and hypnopompic hallucinations. And then, especially for younger kids or people with intellectual disability, also consider imagination and inner dialogue, right? Kids that, like I already mentioned, like the boogeyman, sometimes kids just have really good imaginations, or they have a lot of fear about something, so they imagine things are there. So commonly confuses children, people with low comprehension, and in situations of duress, right? So the real common one here is someone who's grieving, that they say they see a loved one, because they're constantly thinking about them. These are all not related to psychosis. Another way to kind of tell is that, patients generally lack insight into the unreality of hallucinations, which also makes it difficult, because basically what that means is, so look at the differences between these two sentences here. I think I'm hearing voices, right? Where a patient understands that they're hearing something that's, like I said, that doesn't exist, versus someone saying people are talking to me that I can't see, right? If you were really hearing voices, you wouldn't assume that they were just coming out of nowhere. You might assume that you just can't see, who's talking to you. The second one here really plays into this whole disordered thinking and paranoia, right? It's not just an auditory hallucination that's going on. It's more rare to have kind of like isolated disordered thinking, right? Especially with schizophrenia, it's going to be a bunch of these different symptoms. It's not just going to be one isolated thing. So someone who's totally fine and functioning but says they're hearing things, it's less likely to be an issue, right? Versus, like I said, full-blown schizophrenia where people are having auditory hallucinations. Well, then it plays into their paranoia, they're acting on it, there's other things that are going on, and you can tell some of these other symptoms, like the positive symptoms and the negative symptoms that we'll talk about in the patients too. So next we've got disordered thinking and speech. And the reason these are together is there's no real way to measure disordered thinking or to see it. So we kind of, infer it from disordered speech. So yeah, just so right there. Disorganized thinking is inferred from disorganized speech. And the different types that we talk about a lot are loose associations, where patients are saying sentences, but they're not related to each other. So they're sentences that they're fully formed, but there's no paragraph structure to them. Or, they do have some paragraph structure to their sentences, but the paragraph from one to the next doesn't make any sense. They don't have anything to do with each other. Tangential speech is not being able to stay on a goal of talking, like being able to converse with someone. You're talking with someone, they seem to be making sense, but you can't follow where the conversation is going, right? If you find yourself thinking like, wait, I didn't ask about that, or why are we talking about this now, or I'm just sitting here listening to a bunch of different topics, and they kind of go together, but they're not coming back around to answering anything. That's tangential speech. Perseveration is a repetition of sounds and words, so not really, something. It's really close to word salad in that there's no real sentences here. Someone is just repeating sounds, they're repeating words, and you may not even know why they're repeating words. They may have heard them, or they may be something internal. Word salad is really, like I said, it's real words, but in a non-grammatical sequence, so they don't really make up sentences. So we're going to listen to an example of some of this disordered speech. And, even though we have descriptors and, can think of examples of these different things, you'll hear with this next guy, it's really not, it's not like one or the other, right? A lot of times these things kind of blend into each other. And the story behind this is a guy who started recording himself. He wanted to stop his antipsychotics and see, what the process was, how he was while he was off his medication. And so he just kind of like stops his medication, he's weaning off of it, and then he's kind of just recording himself once in a while. And so you can just kind of hear where he is at this point. So take a listen to it, think, and try and just think not just of like, what type of speech are you listening to, but also, how are you able to follow it, right? That's kind of the main way that you do this sort of diagnosis is, gosh, is this clear speech? Am I being...
Okay, so the project is reaching its next milestone. I'm writing the last of the web pages to distribute it. I have no money to advertise it with. I think I can be done with all this sometime next week or early the week after, and then got to start job hunting. And I think I brought up my stepmom's website. She got sick of me doing laundry over at my dad's, so she bought me a washer dryer. And I applied for my first job a week ago today, last Wednesday. And I find out the next morning, I go over to my dad's and he says, well, she wants a website in exchange for the washer dryer. I'll throw in $300. Will you do it? And of course I say yes, because he's done so much for me. And now I know I brought this up. And so that is, I'm probably willing to put in as much as 3 weeks of full-time work into that. And if I get a half-time job, that's 6 weeks that I'll spend away from my project. So I wanted to at least get it in a state where I could distribute it and keep track of the people who used it, grant them administrations for the tests they published and things like that. And that's really about all there is to say. My drunken neighbor is acting up tonight. He doesn't like me. I think that he liked me at first when he thought I was just some degenerate schizophrenic who had nothing going for him, but as it became clear that I was a computer programmer and other things, he really began to dislike me. And I hope that doesn't sound too arrogant, but I think it really bothers him. I think there are other people too around here who probably liked me better when they thought I was just some maybe I'm being too cynical. I don't think so. It's like a documentary I saw on racism. This guy tells the story of his father who, their neighbor, they lived on a farm, and the man who owned the neighboring farm was black, and this man had a mule, and his father did not have a mule. And so one night his father killed his neighbor's mule, and he told his son, if you don't have more than a nigger, what have you really got? And I think it's that sort of mentality. Incidentally, that's about the only time I'll use that word, is quoting somebody else. I hate that word. I don't even like it when black people call each other that. I mean, I understand that they're entitled, but it still makes me uncomfortable. I'm a bit of a bigot, I'll be honest, but I'm very open about it is the problem, and I think it's more socially acceptable to hide your prejudice as opposed to saying, all right, look, yeah, I know I'm a bit of a bigot, here it is, yeah, at least this is all there is to it. It isn't typically done that way, and perhaps I'll learn better. Anyway. The joke I made very briefly was that it's not that I'm a bigot, it's just that I have a little bit of a problem with everybody. And then I go on a bit about the mongrel races of Europe and how if you aren't Dutch, you aren't much. And it seemed so preposterous to me that I thought it was funny. And it only took a couple of weeks before I understood that it wasn't funny at all, because there were far too many people who felt that way about one race or another, that there was a superior race and everybody else was just mud people. But that's the way of the world. It's interesting. Europe was riddled with wars for millennia until it was divided into countries along ethnic lines after World War I. And the few wars we've seen in Europe since then have been because of ethnic divisions, the Slavs and the Croats or whomever. And it is just part of human nature, I think, that we like to live with our own kind. And it's one of the things that makes the U.S. so incredibly unique, is the diversity. And you don't see that elsewhere to the extent you see it here. Along the same lines of thought, after World War I, the British drew up the national lines in Africa and the Middle East. And what they did when they drew these national lines, unlike in Europe, where countries were comprised of a single ethnicity, they took ethnicity and both racial and religious ethnicities, I guess, for lack of a better way to put it. In the Middle East, the Sunnis, the Kurds, and the Sunnis, the Kurds, and the Shia, and they packed them together in the same country, as opposed to segregating them into separate countries. And as a result, Africa has been fucked ever since. And nothing but civil war, bloodshed, poverty, famine. And they have Great Britain to thank for it, more so than anything else. The only reason the Middle East is any different is because of their oil wealth, and it's not much different. There are tyrannical monarchs, and if you want a model for what the Middle East could have been like, look to nations like Kuwait and Qatar, where there is only one ethnic minority because they're so small. And I grant you, in retrospect, you can say that it would have been better otherwise. And you have to look, though, at the possibility of a politically stable, oil-rich region that didn't get along with us on ideological terms, and how that could have posed a threat. But politically stable, economically prosperous countries tend not to start wars. Tend not to. Germany was rising out of a horrible depression. The cases, I heard a German Jew, survivor of the Holocaust, or at least of one of the ghettos, say that he remembered being a child and listening to Hitler give a speech on the radio. And at one point he asked the crowd, what do you want, guns or butter? And the crowd started chanting, "Guns, guns, guns." They said, "For the first time in my life, I saw my father afraid." And, well, a loose association tonight, apparently. A loose association night tonight. I'll go ahead and shut up.
So now let's talk about disordered behaviors. The previous positive symptoms that we were talking about were all about cognition and, how does this disordered thinking manifest as speech. But now these are real just like physical things that you can, physical behaviors that you can see. So there's the classic catatonia that we all kind of know, right? And that's called the negativism, right? When the patients are in a stupor, they don't speak, and they have this waxy flexibility where if you move the patient's limbs, then they'll hold them in that position. I think that's the classic one that everyone kind of knows about when you talk about a canatotic state. But there's another type of catatonia too, right? There's catatonic excitement. And it still kind of belies the fact that the brain is disordered and there's no purposeful movement going on, except that instead of the negativism and the waxy flexibility, there's agitation, there's purposeless movements, there's pacing without regard, meaning patients are seemingly just kind of walking up and down the halls, and if you were to stand in front of them, they're going to walk right through you, right? Patients are not they're not perceiving that they're walking around. It's just part of a movement that's going on. And this tends to be associated with perseveration. So this is the language that tends to be seen a lot with catatonic excitement. And then the more difficult symptoms to treat with schizophrenia, which are the negative symptoms. Things like flat affect, avolition, not wanting to do things, anhedonia, not enjoying things, apathy, just being indifferent to things, alogia, not speaking, and asociality. Again, I know I briefly went over these before. But this picture here, this is flat affect. And before I tell you the answer, which side is flat affect? Okay, because I think that the understanding of what flat affect is kind of difficult until you see it. A lot of people think it's, you may, well, let me just give you the answer here. So the person on the right, that's not flat affect. The person on the left is flat affect. Okay. And the way you can tell is the person on the right looks sad and upset and depressed, right? The person on the left, you don't really know what that person is thinking or what their feelings are. Their affect doesn't display or doesn't transmit any of their emotion. So it's, maybe that patient looks confused, right? But on the right side, you can even see kind of like a furrowed brow, noticing that his eyebrows are dropped a little bit, and his eyelids are a little bit, a little bit more closed, right? There's a look of concern, or like I said, depression, or tiredness that's there. So subtle signs. When I talk to SPs about imitating flat affect, one of the things that we all do when we're talking, even if we're trying to pretend to be, even when we pretend to be flat affect, is our shoulder shrugging. It's incredibly hard to talk to someone without moving our shoulders in a way that coordinates with our speech. So yeah, that's just one thing. Flat affect is just the complete disconnection of, like I said, these unconscious nonverbal cues for our emotion. So what are the actual psychotic disorders we're going to cover? Of course, schizophrenia. Okay, we're going to talk about something called schizophreniform and brief psychotic disorder, and those are both similar to schizophrenia, except that they provide us with different prognoses for a patient reaching schizophrenia. In the same way that when we talked about post-traumatic stress disorder versus acute stress disorder, acute stress disorder was the earlier symptoms that tended to be, like I said, had a better prognosis, and so some of those patients didn't progress into PTSD. That's what brief psychotic disorder and schizophreniform is. And then there's delusional disorder, which is still it's still a condition of disordered thought, but it's specifically just delusion. So it can't involve any disordered speech or abnormal behaviors or any flat affect at all. And then we're going to talk about schizoaffective disorder, which is kind of a combination of psychosis and mood disorders, and we'll get into these things. And then, of course, there's substance-induced disorders. So substance-induced psychotic disorder, and you can imagine, again, like with something like methamphetamine, which is not schizophrenia, it's a substance-induced psychotic disorder, or psychotic disorder due to another medical illness, like a hyperthyroid storm, issues that again can be treated. The DSM-5 criteria for schizophrenia must include, or at least the criteria are, there's basically a psychotic episode, right? In the same way that we had depressive episodes and manic and hypomanic episodes, these episodes must have 2 or more symptoms of delusion, hallucinations, whatever, for a significant portion of 1 month. And these must include delusions, hallucinations, or disordered speech. So none of the negative symptoms have to be there, but delusions, hallucinations, or disordered speech, it must be at least 2 of those. And then there's obviously got to be some sort of lower level of functioning in 1 or more major areas such as work, interpersonal relationships, or self-care relative to the premorbid condition. And then another issue with the timing is that there have to be continuous signs of disturbance for 6 months. And that includes residual or prodromal periods. So even though the full, psychotic episode it only has to be for a month, there has to be some sort of disturbances for 6 months, and that's what we call residual or prodromal periods, okay? So residual prodromal periods are when there is only one psychotic symptom, or there are psychotic symptoms that don't include delusions, hallucinations, or that disordered thinking. So, the assumption is that these are milder versions of psychotic episodes that just don't meet the criteria of 2 or more with delusions, hallucinations, or disordered thinking. So, and then obviously some of the rule out criteria. Rule out other psychotic illnesses, especially schizoaffective disorder, which we'll talk about in a little bit, and then not attributable to substance or medical illness. The next psychotic disorder is something called schizophreniform disorder. So it's schizophrenic-like, right? Schizophreniform. And it's the same symptoms except for the duration of those symptoms. So in schizophreniform, the symptoms are either active, prodromal, or residual. They last more than 1 month, but less than 6 months. Okay, and again, the same way that we did with acute stress disorder and PTSD, it really is more to just get at the prognosis of the patient. If the symptoms have been happening for a year, well then they're probably not likely to go back to a premorbid state. But if they're between 1 and 6 months, there's still a chance that with proper management, patients might not have or they might go into remission. Brief psychotic disorder. So this is the last part of this trio of schizophrenia and the different timelines. So the same schizophrenia, or same criteria as schizophrenia, except for criteria C, which is the length of time. In brief psychotic disorder, it's an episode, again, either active, prodromal, or residual, that lasts more than 1 day, but less than 1 month. Okay, so here's that last piece of, okay, so it's less than 1 month. These patients tend to go back to a premorbid state. There's still a high rate of relapse, but at least there's periods of remission. I figure I should explain this picture because it actually, now that I remember, I had a question about this when I was giving this lecture in a room. So someone said, so are you saying that meth would be, like a meth-induced psychosis would be brief psychotic disorder? And actually, no, it wouldn't, right? Because that would be a substance-induced psychotic disorder. And of course, it's confusing because I have this picture on here, but the reason I have this picture on here is because he's wearing briefs. So, yeah. Delusional disorder is when you have symptoms that only involve delusions, though, and it can be multiple different delusions. But once you start having some of the other psychotic or some of the other positive symptoms or negative symptoms for a duration of 1 month or longer, then you have to start considering the other psychotic disorders like schizophrenia. Schizoaffective. So I'll start by just reading the criteria here. It's an uninterrupted period of symptoms where there is a major mood episode, either depression or mania, concurrent with criterion A of schizophrenia. Okay, so do you have psychotic symptoms along with depression or mania? And yeah, it gets confusing to think about this because is this a separate disorder? Is this a disorder where, like you see this quote here, we don't know if it exists in nature, by the person that's, heads up the psychotic group for DSM-5. Just because you have depression and, maybe even mania during a psychotic episode, is that a separate thing, right? So let's look at it another way. So the whole definition of it is, what we went through before, an uninterrupted period of symptoms where there's a major mood disorder concurrent with criterion A of schizophrenia, but also the delusions or hallucinations for 2 or more weeks without a major mood episode. Okay, so it has to be periods where you have, psychosis the whole way, and then, depression comes on or a manic episode comes on, and then you have periods where you don't have those episodes. And then symptoms for a major mood episode must be present for the majority of the total duration. Here let's look at it again another way. So schizoaffective, you've got the psychosis that's going on throughout the entire time, and then you have these periods of, let's say, depression. And I want to show that in contrast with a mood disorder with psychotic features. So let's say you have depression the entire time, but then you have periods where you have psychotic or psychosis, psychotic symptoms. Okay. So for example, you could have depression, but then you start having symptoms of having delusions and a flat affect. Okay. So the timing of these things that's not what's super difficult. It's just, like I said, is schizoaffective really that different from schizophrenia? Okay, and there's a lot of debate on that. That's basically what the confusion is. A little bit about substance medication induced psychosis. In the substance use lecture, we had a video of a woman who was having a meth-induced psychosis. So she was definitely having symptoms of hallucinations and delusions that were going on. And so that's what these are. They're generally only hallucinations and delusions. Now, one of the things that's important to set up differently is that it's not the same as delirium, though. Okay. And this gets a little tricky, and maybe it's a little semantics too. But, delirium is acute fluctuating confusion, right? Changes in cognition. And, they can lead to perceptual differences and things like that. But delirium really is more, like I said, the changes in cognition and fluctuating confusion. Now, these things are usually due to like a metabolic imbalance, infection, vascular compromise, like a stroke or an MI, psychological or physiological stress, right? It's really common to see the type of delirium where a patient is recovering from surgery or a major traumatic event, and they wake up in the hospital and they're completely confused. They're walking around the halls, not know what's going on. That's delirium. The confusing part about substance and medication-induced psychosis is that sometimes delirium can also be caused by substances, right? And so in that sense, it really is, the symptoms you're just trying to tease out is different, but the management of them is the same for those two types, okay? Now, the managements are different between psychosis and delirium. If it's just caused by a substance, you need to stop the substance, okay? So the common causes of substance medication-induced psychosis, obviously anything that has hallucinogenic properties to it, like PCP and inhalants. But, the stimulants also have a good amount of it, and even some sedatives are included on this list too. So alcohol, cannabis, PCP, inhalants, amphetamines, and cocaine. Choosing an antipsychotic. Now, I really want you to focus on just a couple different things here. I'm going to go through a lot of details just so you understand the differences in the medications, but really it comes down to this. Just focus on being able to identify which antipsychotics are first generation versus which ones are second. And the reason I want you to know that is because there's big differences in the effects and side effects of FGAs versus the second generation ones. So that's the main thing. And it's not just a fact of, well, it's beyond the course. It's just there's so many different prescribing patterns out there. If you get 3 psychiatrists, you're going to have 3 prescribing patterns. Okay, if you've got 3 different patients, you're going to get 3 different patterns on those patients. Okay, the efficacy of most antipsychotics is similar. Okay. All except for clozapine that we'll talk about. Clozapine is used more for refractory or medication refractory schizophrenia, but you really have to be committed to using it because it's got a lot of nasty side effects. Really, the point is that the choice of medication is correlated to the patient tolerance and provider preference, kind of just like which medications as a provider we're used to using, which ones we're comfortable with, which ones we see personal success with. But, patients aren't going to take a medication if they don't like it. And it's really, that compliance is a real big issue with schizophrenia. So it's important that the patients are on board. Here are the list of all the lists of medications that you'll commonly see. On the left side are the first generation ones, and the second on the right side are the second generation. So we kind of separate them out, and I've taken some out just to make them the ones that are a little bit more commonly used. So for the first generation, the real big thing here is you're going to see more of these movement disorder side effects, things like extrapyramidal syndrome, tardive dyskinesia, and you can have more hyperprolactinemia with first generation antipsychotics too. And we'll go into APS and TD here at the end of the lecture. For the second generation ones, they tend to have less of those symptoms, but they have more sedation and weight gain involved with them too. Now, that can be a good or a bad thing, but it's important to know the difference between the typicals and the atypicals. And it's interesting, obviously that's a historic phrase now because really the typical ones or the more common medications or antipsychotics you see now are the second generation ones, but that's still how they're referred to in the literature, or typicals versus atypicals. A little bit of receptor physiology here. We talked about this before. In general, the antipsychotic property of antipsychotics is due to the affinity to the D2 receptor, okay? And it's actually you kind of have to break it down into 2 independent things. One of them is how many receptors are actually being blocked, right? The dopamine antagonism part. So that blockage, that's related to the efficacy or how well the drug works. once you reach the 60–80%, then the drug is effective. Okay. Receptor affinity, though, on the other hand, is different. And receptor affinity is what's being shown on the chart here, where at the top of the chart you have a loose receptor affinity, and the bottom of the chart is a strong receptor affinity, where once they bind, they stay stuck to the receptor. And then at the top, things like quetiapine or Seroquel, that has a looser binding to it. Now, you kind of like think intuitively, well, doesn't that mean it's less effective? No, it just means that the binding is looser. It's as long as you still have the percentage of receptors affected, you still have the efficacy. But the looseness of it, or that receptor affinity, is more related to the side effect profile, and specifically with the EPS tardive dyskinesia profile. Okay, so a loose affinity or rapid dissociation in atypicals is possibly, that's why you have a better side effect profile for those second generation antipsychotics, along with that D1 activity that we talked about before. Okay. And then, what's another difference in the first generation versus the second generation? Well, the second generation ones tend to have dopamine and serotonin blockades, okay? So generally, it's all those they have some sort of activity with serotonin too. Some of them are antagonism, sometimes they're partial agonists, but this always leads to decreased EPS, TD. And again, it's neurology, so there's a bunch of different things to kind of take into account. But that's the big difference between the receptor activity of atypicals versus typicals. For typicals, it's going to be mainly just dopamine antagonism, versus the newer medications we have, the atypicals, they also include serotonin response too. So now I'm going to talk about the typicals, and really the only typical antipsychotic I want you guys to know about is haloperidol. Okay, it's known as the classic antipsychotic that we use for schizophrenia. Classic as in definitely older, try not to use it all the time. It's what we consider a high potency typical antipsychotic. So it's got low weight gain, it's got all these low side effects related to the other receptors. So low weight gain, hypercholesterolemia, QT prolongation, anticholinergic side effects, moderate sedation, and then it really has a high risk for the extrapyramidal syndrome and tardive dyskinesia and prolactinemia, and that's just because of its binding receptor affinity. Now, efficacy and potency are not the same thing, so this is really another one of those semantic things where we call this high potency. It doesn't mean it's high efficacy. Okay, all of these typicals really have the same efficacy. Potency really just relates to dosing and the side effects. So here's a good example. Potency, so Haldol is really high potency in that you've got effective doses of it at like 5 milligrams versus something like Seroquel, you've got effective doses of it at like 200 to 600 milligrams. That's what I mean by potency. But it doesn't change the efficacy of it. Okay, it's more related to just how much your liver processes it and how much it gets into your bloodstream before it starts affecting the 60 to 80% of those dopamine receptors. Moderate potency ones, trilofan, thiothixine, you definitely see these used in modern practice still, but they're moderate potency, so they're low on the anticholinergic side effects, orthostatic hypotension, QTC prolongation, and moderate weight gain, EPS, and prolactinemia. So again, no, you don't need to memorize too much about these. I just wanted to, for completeness, basically. You still see some Thorazine used out there, and here's a good example of the difference between high potency and low potency. Again, it has kind of the same efficacy, but the amount that you would need to use in a patient is closer to like 300 to 800 milligrams of this medication, Whereas Haldol, it's rarely see much more effects over 30 milligrams per day. So again, it has nothing to do with the efficacy. It's just how how much dosing you need. Interestingly enough, too, this actually, if you talk to someone based on just how they use it, Thorazine is still used a lot because you can see here the side effects are high for things like sedation. Okay. So it's a really good medication when you need something for an acute agitation, like a patient comes in and either they have psychosis or, like I said, just completely agitated, and you really need to kind of get them sedated. Well, this medication is going to seem like it's higher potency because, that if you're using it in layman terms, like just really potent, because it'll knock someone out. Okay. So here's just a a slide that you guys can use to look at some of these symptoms. Again, the basic thing here is you notice the D2 antagonism. That's really going to be helping decrease your positive symptoms, so that's good. The problem is, the really strong D2 antagonism is going to cause lots of EPS and increased cognitive symptoms like memory loss and confusion. Partial agonism tends to be a little bit better because then we get all of the decrease in all the signs of psychosis and a decrease in the side effects. And so that's what you tend to see with our newer antipsychotics, is you tend to see partial agonism instead of total antagonism. The rest of these things on here, they're more for just your information. We'll cover them as we go through the rest of the slide, but you can see the additional properties of these different second generation antipsychotics. It's the main reason that we're still seeing a lot of new ones is because we're getting good symptom control but decreased side effects too. So atypicals have several subtypes related to their receptor affinity. Okay. Again, most of them are serotonin dopamine antagonists, right? Those are I guess this would be the earlier atypicals, or the first atypicals that came out. Things like risperidone, paliperidone, ziprasidone, iloperidone, and lorazepam. So the antipsychotic effect with both the negative and positive symptom efficacy and decreased EPS. So right, all good things there. And then the newer, so almost like what we would call the third generation of antipsychotics, are really the multi-receptor antipsychotics that have a lot of different effects that aren't just strict dopamine and serotonin. They affect a lot of different things. So again, we kind of alluded to that on that first slide. A lot of decreased EPS, but also changes some of the other side effects that we have a problem with, like things like QT prolongation and sedation and weight gain. And there's no perfect antipsychotic out there. So what we have are the options of these different second generation antipsychotics to work with patients on what they prefer, what they can tolerate. Now we're about to go into about 10 or so slides of specific medications, and I'm just going to mention some very basic things. This lecture used to be this part of the lecture used to be in my talk that I gave at the state conference for antipsychotics. So we kind of go into a lot of detail here, but I just want to mention things, and I'm only going to mention things that I think that are important. But again, just focus on being able to identify all of these as second generation, and that really it's the side effects that they tend to have less of those EPS and tardive dyskinesia side effects. That's what I mainly want you guys to know. And what I'll talk about over the next few minutes here is just things that make these medications stand out from each other. Clozapine is, like I said before, it's for treatment-resistant schizophrenia, and it's probably the only one that really has a better efficacy than the other ones. But the reason we don't use it that often is because it really has a nasty side effect to it, and it's not even the side effect of tardive dyskinesia or extrapyramidal syndromes. It's agranulocytosis. So patients, first of all, you have to be on a registered list in order to, for patients to be on this medication. They've got to submit to a CBC very, very often, especially when they're initiating the medication, to check their absolute neutrophils. So it's something that you really only use when you absolutely have to, because it's definitely has nasty side effects. Fanapt, nothing. It's a good medication. You definitely see it out there a lot. Definitely just one to know if you're having problems finding one for patients that one that patients like. But nothing too extraordinary about Fanapt. Risperdal, you'll see a lot used in kids. It's a commonly used medication in kids, not for psychosis necessarily, but for agitation and aggression that's not helped with SSRIs. The big thing here is that it was really involved with gynecomastia. Johnson & Johnson paid a huge fine on this because they really reduced the the kind of the reporting of how common it was and the how big of a problem it was. So if you do use this medication, you have to follow prolactin levels. Zyprexa, boy, this is another medication that, so in recording this lecture right now, there was a study that came out a little bit ago that suggests that Zyprexa, long-term chronic Zyprexa use was related to cortical thinning. Now, they didn't really have any, other association with cortical thinning to cognitive function, but yeah, it'll be interesting to see what happens, because this is very popular medication. It's used a lot in acute psychosis, so you'll see it used a lot in the ER for patients that come in that are agitated. But chronic use, it'll be interesting to see what the studies kind of show in the next few years. Seroquel is one that you'll find a lot. You'll see it a lot. The side effect that it has that people actually like is that it's a pretty good sedative medication. And so it acts really well as an anxiety medication. You'll see this a lot as an adjunct to SSRIs. Even though any antipsychotic can be used as an adjunct to depression and anxiety treatment, you'll see Seroquel a lot for anxiety. But the problem is it tends to cause a lot of confusion and agitation in the geriatric population. Gedon, good med, but it can have some issues with diabetes and metabolic syndrome. Saffris, it's another newer medication, but it's a sublingual tab. Patients tend to not like it a lot. Latuda, nothing really special about Latuda. Again, it's just another option we have when patients don't prefer any of the other medications. Abilify and brexpiprazole. So Abilify, probably, I want to say it was like 10-ish, 15-ish years ago, was the kind of big medication that came out in psychiatry. It's what we would consider a third-generation antipsychotic. And because of its particular receptor affinities, it's a great med that has good efficacy but has a really, really low side effect profile. The newer version of it, brexpiprazole or Rexulti, is just going more in that direction of reducing the side effects. So patients really can tolerate this one. So Abilify is a good med. If you're just using medications you don't feel comfortable with, antipsychotics, Abilify is not a good place to, or not, it is a good place to start, and a very low side effect profile. Vraylar is also another one of the third generation medications. Vraylar and Rexulti probably have been out at this point probably 4 or 5 years now, maybe even less than that. But more of these third generation medications, just trying to get onto the success of Abilify. So here's a couple different charts I just want to show. So this is from a single hospital, the most common for first episode psychosis at the same university hospital, one created in 2005 versus 2010. So it's going to be a lot different now in 2020, But just the change, just to show you guys what are the medications that are being popular and used. So, you know, in 2005, you still saw a lot of haloperidol, and then you saw a lot of use of Abilify, aripiprazole, in psychosis too, because it was a new medication at the time. They wanted to test out the effectiveness of it. What we see now is that Abilify is really more used as an adjunct to depression and anxiety, and in chronic treatment of psychosis. But really, for acute use, we don't see it that much. Really, the ones you see a lot are still like, you know, risperidone and Zyprexa. So the last topic of this lecture are the side effects of antipsychotics. And to be honest, I think this is probably the more important thing from a family medicine standpoint, because patients that are taking antipsychotics chronically, that's going to be managed by family medicine too. I mean, of course, psychiatry is still involved, but it depends on, you know, it really is just more who catches the symptoms, okay, who's seeing the patient at the time. And there's two major ones, okay, extrapyramidal syndrome and tardive dyskinesia. And the big difference between these two things is that extrapyramidal syndrome or extrapyramidal side effects, those tend to happen early, okay? Within 48 hours of taking the medication, usually within the first few hours, you'll start to have these EPS signs. Tardive dyskinesia, though, is a chronic, it's basically, well, tardive means late, okay? Dyskinesia is, you know, difficulty with movements or mismovements. And so EPS happens early, tardive dyskinesia happens at the earliest 3 months, but more likely 6 months out, and it can occur years and years afterward. You know, some studies show that with haloperidol, if patients get to 10 years of chronic use of haloperidol, they're about 50% chance of having tardive dyskinesia. So it's something you always have to keep an eye out for. Whereas EPS, if patients get through that first week without it, they're probably not going to have EPS. When we talk about EPS, the main things are akathisia, pseudoparkinsonism, and acute dystonia. Akathisia is really just like restlessness. Okay, patients just feel like they don't feel comfortable sitting, they have to move around, they can feel agitated. It's the most common one, and it's difficult because when you're using this in psychosis, patients can be agitated anyway, so it's hard to tell the difference. Pseudoparkinsonism, that's basically it's basically Parkinson's. Okay, it looks like Parkinson's disease, bradykinesia, shuffling gait with a tremor, and so again, this one tends to happen a little bit later than within the first few hours, but you definitely see it early. And then acute dystonia, which happens pretty early. This happens within the first few hours too of use. This being really, really painful. So shoulder, neck, lower back pain and tension, almost like a cramp, where patients can't move. You know, when you think of like dystonic events and you know, those types of things, like that's what you're seeing here, like a torticollis type situation. So it's really painful, and it's just a constricting, and they can have eye rolling associated with it too. I don't want you to have memorize this chart on here. It's just to realize, yeah, when we look at typicals, most of them have a high risk for these movement disorders, whereas atypicals, they tend, the majority of them, and especially the newer ones, tend to have a low risk for EPS and tardive dyskinesia. Something we do is we really monitor these patients when they first initiate these drugs, and what you see here is a chart that just shows, hey, when we started paliperidone, these are the symptoms that we saw. When we started aripiprazole, this is what we saw. So this patient here has gone through a few weeks of paliperidone treatment, switched them over to Abilify. A few more weeks, then we started seeing symptoms again, so they switched over to Seroquel, and you can see the titration of Seroquel. And then finally, a patient that was started on clozapine and then titrated with clozapine. You can see the SAS score, the higher numbers mean more of these EPS signs. So you can see we had to keep switching them because this patient really had a high level of them with these first 3 medications, but we got them off of Seroquel, started them on clozapine, and then we started seeing reduced amounts even with the high titration. So that's just I just wanted to show you one of these. These are the symptoms you look for. You evaluate their gait, look for their arm dropping, like if they're having difficulty, raising it, shoulder shaking, elbow rigidity, wrist rigidity, leg pendulousness, head dropping, glabella tap, which means if you tap on their glabella, do they blink? Okay, it's just an uncontrollable reflex that shows an extrapyramidal reflex, tremors, and then salivation. For the management of akathisia, basically you can start with reducing the dose. Okay, consider a dose reduction or switching to an agent with less EPS tendency. Okay, medications, if the patients have to be on the medications, and that's the only thing that works with their psychosis or agitation, then you can also try propranolol. The other one too is you can give cogentin. Cogentin can help. That's kind of our main EPS medication is benztropine. We used to use benzodiazepines in the past, but it's not good to give benzodiazepines to patients that are schizophrenic or possible drug problems. For the pseudoparkinsonism, right, that tremor and bradydyskinesia, reduce the dose, switch the antipsychotic, or go straight to cogentin. For the acute dystonias, because these things, like I said, they're super painful, the medications are still, cogentin, but don't give them oral cogentin. Go with a shot of cogentin so they can get that right away. Diphenhydramine is exactly what you think it is. It's just Benadryl, okay? You can give them a shot of Benadryl too. And it'll help because it just relaxes the muscles. Cogentin is very similar. It's got the same anticholinergic effects, but it's just a long-term medication, whereas Benadryl is obviously, it's a short-acting acute anticholinergic. If the dystonia continues and you still can't stop the antipsychotic because you don't want the patients need to be on it, then yeah, PO benztropine long-term is recommended. And I put that in quotes because it's not a great med to be on. Okay, it's an anticholinergic, and a lot of studies recently that are kind of connecting anticholinergic effects with dementia are really kind of scary. So if you haven't looked up those things, look up anticholinergics, because obviously anticholinergics are everywhere. So I think we just have to be careful with how much anticholinergics we're giving chronically these days. So tardive dyskinesia is a side effect that's a neuromuscular side effect that involves the mouth, tongue, and face. And that's what this video is here, showing different levels of that. And a lot of jaw protruding, tongue protruding, and that's usually where it starts. But there's also involuntary movements of the upper limbs, lower limbs, and the trunk. And we'll talk a little bit more about that too. So it generally appears late. That's what gives it its name, tardive. It's really early would be 3 months, but really it's more likely you don't see it until 6 months. And the risk of it doesn't go away, like I was saying before. So it really is a, if it's not caught, it's a really debilitating side effect. And the other tricky thing about it too is that it can appear as a withdrawal symptom from an antipsychotic. So, and this tends to happen more in kids, but you're weaning a kid off of one of these antipsychotics and then they pick up tardive dyskinesia. So that can be difficult. We talked about this, the side effects being less common with the atypicals, but for tardive dyskinesia, it is less, but not by as much as you'd hope. So the risk of even when you're using the secondary second generation ones is still high. The other thing here too is that for patients, if it's more common when patients are using antipsychotics when they're younger. And if you see tardive dyskinesia in a younger patient, it tends to be more permanent. So for the symptoms, tongue protruding, twisting tongue, mouth, you get lip smacking, pouting, puckering, retraction of the corners of the mouth. You get the jaw moving left and right. And then you can also get something called blepharospasm, which is just, it's a spasm of the eyelid, which can start as rapid eye blinking and facial tics. And then, the more severe part of this early part of tardive dyskinesia is the difficulty swallowing, speech, eating, and then breathing. Obviously, that's going to be a problem. But these oral facial symptoms, they tend to appear first. And then that progresses into the limb and trunk involuntary movement. So shoulder shrugging, torticollis, rocking, swaying, leaning, like balismus movement. So there's like really wild flinging of the arms, and choreo-like movements too. So just like the writhing dance type movements of the upper or lower limbs. Finger twiddling, spreading, twisting, foot tapping, toe extensions. And then for the trunk involvement, like posture abnormalities, where someone is just, like I said, writhing, or they're just postured in a very odd way. So I showed you a little clip of that, but you can look up that online. It's the videos for evaluating tardive dyskinesia, or the abnormal involuntary movement scale is AIMS. Again, most common is then earliest manifestation is those oral facial movements. And for any patients that are on chronic antipsychotics, they definitely need to be watched for this, because it's something you have to catch. One of the things that's really concerning about tardive dyskinesia is that it can persist for a month after stopping the medication or be permanent. So you really just have to be careful with antipsychotics. It tends to get worse with stress, it improves with sedation, and it goes away with sleep. And this tends to help with diagnosis of this tardive dyskinesia versus some of the other neuromuscular disorders. If it's not obvious, then go to neurology. This is just another one of those places where neurology and psychiatry tends to cross paths. Management. Obviously, discontinue and taper the antipsychotic. If the patient absolutely needs to be on antipsychotics, then switch to an atypical. Seroquel tends to be an interesting choice because it has that extra sedation, so we're going to actually help with some tardive dyskinesia too. And then for patients that have like really disabling psychosis, even when on antipsychotics, consider switching to clozapine as their antipsychotic, even though, like I said, with a high risk. But if you're still having the psychosis, then switch to at least attempt clozapine. It tends to happen a lot in institutionalized patients, because that's, of course, where the severity of psychosis is pretty high. For the management of actual symptoms, for patients that have specifically the cervical dystonia and the blepharospasm, you can use Botox for them, for a relief at least until the antipsychotics wear off, or if it's a permanent symptom. Benzodiazepines tend to help because of the sedation, but studies kind of suggest that the tardive dyskinesia comes back after long-term use. The tolerance to benzodiazepines obviously is pretty well known. And then we have our VMAT2 inhibitors, so things like tetrabenazine, valbenazine, and deutetrabenazine. These are medications that if a patient absolutely needs to be on antipsychotics, and maybe they can't, they still have TD with clozapine, or they can't tolerate clozapine, this is another way to go. So The short-term effectiveness is definitely good, but they're relatively new medications, so not a lot of long-term studies yet. For management, stay away from anticholinergics. And the reason I mention this is because things like trihexyphenidyl, benztropine, and Benadryl, they tend to worsen tardive dyskinesia. And it's just that EPS and tardive dyskinesia can look very similar to each other, right? So cogentin and artane are things that we use for EPS, but they'll make tardive dyskinesia worse. So how do we differentiate from extrapyramidal syndrome? Really, it's when we're looking at the symptoms, it's rigidity versus excess involuntary movements. Okay, EPS tends to be that cramping rigidity in the shoulders and neck, but tardive dyskinesia tends to be involuntary movements and more of the limbs. Also, with EPS, it tends to be shoulder pain, rigidity, and tightness, again, versus shoulder shrugging. That's just kind of an example. But the main thing is the timing, okay? So if there's a side effect and it's going on within the first month, it's probably going to be EPS. Anytime within that past 6 months or, possibly within 3 months, then it's more likely tardive dyskinesia. The tricky thing, though, is let's say you have a patient that's been on an antipsychotic for a year and you increase the dose. Now, EPS can happen from dose increases too. So even though the patient's been on the medication for a year, it's more likely that it's EPS. It doesn't rule out tardive dyskinesia because, of course, they could always get the tardive dyskinesia because they've been on the medication chronically, but because of the change in dose, it's more likely to be EPS, and so that's why you kind of have to go back more for symptoms at that point. We've been approaching this from kind of an outpatient medicine standpoint, but just a couple tips and some things to know about if you encounter psychosis acutely. First, you have to assess for danger to self and others. And then admit the patient to the hospital. This is if a patient shows up to your clinic. Once they get to the ER, you can do treatments with rapid-acting first-generation antipsychotics like Haldol or Zyprexa or Geodon, and even obviously benzodiazepines like Versed here can work to kind of treat psychosis or the agitation going there, and then make sure you do a referral to psych. As a health provider, though, there's other types of, the non-pharmacological treatments, or at least treatments that go along with pharmaceuticals, and these are detentions and commitments. For detentions, the initial step, what you usually see is like a 24-hour immediate detention, which usually can be initiated by a police officer, right? So this situation is someone calls the police because there's a patient or someone's acting erratically and they're deemed to be a mental health concern because they're a danger to themselves or others. Well, this is called an immediate detention. The police officers can bring this patient to the ER, and an evaluation must be done by a psych health provider within the first within 24 hours. At that point, the patient can be released home or voluntarily go somewhere for help, or they can undergo an emergency detention, which usually lasts 72 hours. So this can be initiated by the police officer, family member, and a physician at that point. Okay. So this also has to be sent to and approved by a judge before the admission to the hospital. So we start off with a patient that's acting erratically out in the out in the community. Police officers can initiate a 24-hour detention. Patients end up in the ER, and then at this point, the police officer or a family member, with the help of the physician, can initiate a 72-hour hold, which means generally that they get sent to a more psychiatric facility, usually for acute treatment. At that point, the patient can then voluntarily remain for treatment after that 72 hours. Or if the patient does not want to stay after that 72 hours, but the psych provider still thinks that the patient requires treatment, then there's something called a physician and judicial hold. So this is during the course of any voluntary treatment or even in the 72-hour treatment. Physician determines that the patient is dangerous to himself or others, and in order to stay at that point, the physician must prove this to a judge. So this is generally short-term treatments, though, for acute care facilities. After that, though, if it's deemed that the patient needs to be committed, this is a much longer legal issue. And so, again, if the physician can prove to a judge that an involuntary commitment needs to be done, these are done at like state institutes, state hospitals for longer stays. So temporary ones tend to be up to 90 days, and there's an evaluation that's done every 90 days, which at that point during this time there could be a longer commitment that's indefinite with an annual review. So that's psychotic disorders. If you guys have any questions, just let me know. Thank you so much.